a few times, she's from Haifa, so thank you so much for coming.
Thank you, the Scientific Committee and Eran for inviting me to this meeting, to lecture. And thank you all for staying to the last afternoon lecture to get the cherry on the cream. My lecture on the fascinating issue of deep neck infection. It's basically intended to be a radiology resident survivor guide. And so the objective of this lecture is to guide you through this maze of deep neck infection so you can safely get from the back station to your bed and get some rest during the night shift, and also vice versa, to prevent the occasion that you need to wake up the attending to help you with a complicated case of head and neck infection. So we're gonna review the relevant anatomy and review the clinical and imaging approach for deep neck infection. We're not gonna talk, so you can invite me to another lecture on sinusitis, ofodontogenic, and orbital infections. Do you hear me? Is it okay? Yes? So what are the challenges in neck imaging, and why do we all leave those cases to be done last? It's a crowded region with a lot of critical structures, airway, important vessels, the nose, and the 3D relationships are difficult to understand and visualize. And it also, especially if you're not doing it a lot, it's difficult to communicate the imaging findings in a meaningful and precise way. And also, sometimes the symmetry principle is not that helpful because you wonder which side is the normal. And another issue is that this is a part that represents the head and neck. Some of us earn a lot of money from that. And everything you do might harm this critical ear area. So what does the clinician want to know when he refers a patient for a study in questioning about deep neck infection? He wants to know the airway status. He wants to know when to operate, is there a need for operation, what procedure to perform, internal or external drainage, and possibly the source of infection. So what we should do is look for airway compromise, look for the source of infection, look if there is a collection to drain, and evaluate the extension of infection and possible complications. So where is this deep neck that we are going to look for infection in? So the deep neck is basically inside the superficial. Oops, I'm missing the word. It's deep to the superficial cervical fascia. We have the superficial cervical fascia, which is just under the skin, and it contains the platysma and external jugular vein, and it runs all the way down to the thorax and axilla. So deep to it, we have the deep cervical fascia, which is divided to 3 layers. The superficial layer, which is like not that a good term, but this is the superficial layer of the deep cervical fascia, and that's encircle the entire neck. That's the over here. No. Okay, and let's start the black line over here. And then we have the middle layer that encircles the neck structure deep inside that are more anterior, and we have the deep cervical fascia that encircle the neck structures around the spinal column, just as a general term. And so what does the deep cervical fascia does? It creates subdivisions within the neck, separate some compartments. This way, on the other hand, you can limit the infection spread, but also if the infection is limited to a certain space, that increases the pressure and thereby can compromise the airway. Also, if you know the spaces, you can locate the source of infection and try to find what's the causative source. And also we have spaces that cross the entire neck and continue to the mediastinum and serve as a way of infectious spread. So what are the spaces? First of all, you should know that we divide the neck to suprahyoid, above the hyoid neck, and hyoid bone, which is basically neck and face. All the facial structures are here, and the infrahyoid neck, which is like, let's say, the neck proper. So there are certain spaces that are limited to the suprahyoid neck. Sublingual and submandibular, we're going to take one later. We have the parotid space, just posterior to the mandibula. We have the parapharyngeal space, deep inside, contains fat. The masticator space, and that's about it. And then we have the spaces that traverse the entire length of the neck, which are the pharyngeal mucosal space, the parotid space, the retropharyngeal and danger space, and the paravertebral space. Let's skip that. If we try to determine what study to perform, what are the imaging guidelines, CT is not a bad word in imaging of deep neck infection. It is the imaging modality of choice. And why is that? We can see bony details, you can see the teeth or tooth in the sockets, you can identify sialolith in case of sialadenitis. So this is your choice, and also some of the patients might be critically ill, so you can scan them first fast in the CT. Whether to use or not to use contrast, well, you want to use contrast. The question is whether also perform a non-contrasted study to look for calculi. If you don't suspect calculi, you can skip it. I think that in most of the time you can even see the calculi with the contrasted study. You want to use high resolution bone algorithm to get all those fine bony details, and you must do MPR reformations. MRI is good in pediatric cases, some pediatric cases, and also if you suspect paravertebral space disease and disease of the spine. And ultrasound can be used for the parotid and if you want to drain an abscess. So how do you assess the airway? First of all, don't scan a patient if his airway is not secure. The clinician should secure the airway before you scan the patient. The upper aerogenic digestive system, the diameter is very variable. It changes with inspiration, and sometimes you think like the airway is almost obstructed, but the clinician tells you it's not that bad. And we have normal measurements for the trachea, which is more stable and with a size fixed by the tracheal rings. So let's move on from the anatomy and general idea to the actual disease. So what are the main sources of deep neck infection? most dental disease, then tonsillitis, after that Tonsillitis, and we can also have trauma, and of course patient with immune suppression with bizarre disease, trauma, and you can also include IVDA, IV drug abusers, which is like a kind of trauma. And we're going to talk about those three. So how does an odontogenic infection develops? When there are two types. One is the periodontal disease, which is influenced by the deposition of dental plaque over the gingiva, and this plaque initiates an inflammatory reaction between the crown and the gingiva, and that loosens the periodontal ligament that attach the root to the bone. And then you can get the eventually resorption and recession of the gingiva and resorption of bone with subsequent tooth loosening. The other tooth disease is dental caries, which is basically the crown dissolution by acid metabolites produced by bacteria fermenting your favorite chocolates, carbohydrates. Oops, just a second. And both processes can lead to the development of an abscess at the apical part of the root. And this abscess can go in many directions. So if we look, this is the bone, let's say the maxilla, and this is the tooth, and the pus goes out, and it can go into the buccal region, it can go up to the maxillary sinus, and from there to the orbit. It can go inside into the oral cavity, and it can also go posteriorly to the parapharyngeal and masticator space. In the mandibular region, we have the mylohyoid line that determines where the infection should go, will go. So the mylohyoid is a muscle that is spread between the two mandibular ramuses and attaches to the hyoid and has a free posterior border. The sublingual gland lies above it, and the submandibular gland lies below it. And they both are interconnected because there is a free posterior border. So the mylohyoid attaches to the mandibula. You can see it here. And if the root is superior to the mylohyoid line, which is true to all the tooth except teeth, except the last two molars, the infection will go towards the submandibular gland, which is superior to the mylohyoid. And if the root is below the mylohyoid line, it will go towards the submandibular region, which is below the mylohyoid. And you can also see it on the CT. This is the sublingual gland, this is the submandibular, and this is the mylohyoid. So what types of odontogenic infection do we have? You can have apical, periapical abscess, deep neck infection or abscess, odontogenic sinusitis, and so on. I will show them. So this is a case of an apical abscess. You can see the root in the maxillary bone with a hypodensity representing an abscess, and also reactive sinusitis in the maxillary sinus. So the issue of odontogenic sinusitis is interesting because odontogenic disease might be mistaken for sinus disease and vice versa. If somebody comes with painful teeth, it might be from tooth. correctly, whenever. It might be from a sinus disease, or it might cause a sinus disease. And this is the case of a sinusitis that developed after a tooth extraction from the maxillary sinus, which created an oral maxillary fistula and chronic sinusitis in the maxillary sinus. The abscess, as I said, can go to the masticator space, and this is the case of pterygomandibular abscess, which is an abscess in the medial aspect of the masticator space, medial to the mandibula. Otherwise, it can be also lateral and lateral to the mandibula, but this is a medial pterygomandibular abscess. After extraction of a wisdom tooth, 4 days, which developed 4 days after extraction of the wisdom tooth, and you can see the empty socket here. So not always you will see the tooth inside. Sometimes you will just see the empty socket from tooth extraction. And this is images of the same case when you can see that the inflammatory reaction also goes down to the pharyngeal space, and there is also haziness of the parapharyngeal fat and submandibular fat. So you look, the disease is well spread over the deep neck, and you need to find the center of the disease. And in this case, once you identify the abscess, you know this is the most central part, and then you try to find the other details. And this is a case of a submandibular abscess that developed from a cavity in a 2 or 3rd molar tooth in the lower, in the mandibula. And you can also see the bony changes that are seen in such disease. It doesn't imply osteomyelitis. It can also be related to chronic bony changes from the chronic inflammation. And you can also see other signs here, yeah, you see it, of infectious process in the neck, which is haziness of the subcutaneous fat, some fluids around the facial planes, and the active lymphadenopathy. And this is a 69-year-old lady that came complaining of a pain over the left cheek, but the source was from a bad tooth in the maxilla. And you can actually see the air dissecting through the root canal and the bony defect with an abscess near the Ludwig angina is a specific type of odontogenic. It's also presented here with the odontogenic infection. It is a rapidly progressing neck cellulitis that originate in the sublingual and submandibular spaces bilaterally. There is a high risk for airway compromise, and the patient will present with tachypnea, drooling, and dyspnea. The neck will be tender and firm with no fluctuation, and it's presented here because 70% of the cases are of odontogenic origin. Diabetic and immunocompromised are at risk, but it can also occur in the pediatric age. And this is the case from the literature, with diffuse infiltration of the submandibular and sublingual space, and with action formation maybe of an abscess and thickening of the platysma and facial plates stranding. And necrotizing fasciitis is presented here because of the similarity of a fast developing neck infection. It's not always related to odontogenic infection, but it is an infection of the deep neck structures strep is the most common pathogen, and it happens in an elderly and immunocompromised patient. Initially, you get a non-specific neck swelling and erythema, but rapidly there is progression to sepsis, shock, and multi-organ failure. So you need to identify and treat it fast. And this is the case where you see the thickening of the platysma, subcutaneous fat reticulation, myositis here in the near the masseter muscles, and when you see the gas bubbles, hope you see them, those are pathognomonic for necrotizing fasciitis. Those patients should be operated fast and go to the ICU. And this is yet another case in which the origin of infection was an odontogenic one. You can see the diffuse neck infiltration also affecting the pharyngeal mucosal space and the larynx. And this is all happening because you didn't brush your teeth and you got this dental cavity with periapical abscess. Also, he was diabetic, etc. So the next focus of infection is the tonsils. Well, acute tonsillitis is a very common disease, and luckily not that much image. You take a throat swab, you take antibiotics, it goes. You image when there is a possibility for complication, which are mainly an abscess. And this is a case of simple tonsillitis. You can see the enlarged tonsils and the striation, which is typical of the normal structure of the tonsils. And this image was done because the patient also had some neurological deficits, so he had a CTA of the neck. And peritonsillar abscess, which is a complication of tonsillitis, develops in the peritonsillar space, which is located between the tonsillar capsula and the superior pharyngeal constrictor muscle. This is the tonsil, this is the constrictor, and it's in between, inside the pharyngeal mucosal space. And those are the anterior and posterior tonsillar pillars. Patients are usually young adults or children and will present with dysphagia, hot potato voice, and despite antibiotic treatments for tonsillitis. And you should know that true tonsillar abscess is rare. Many times clinician will ask you, is that a peritonsillar or a tonsillar abscess? You can tell them that I said it doesn't matter. The treatment is the same. So this is an example of a peritonsillar abscess. You can see the tonsil pushed and the hypodense collection in the tonsil. And this is another view of the same patient where you can see the tonsillar abscess, peritonsillar abscess, sorry. And this is another case in which there is no collection, but there is some peritonsillar edema, meaning it's the tonsillar infection spread outside of the limits of the tonsil, but didn't create any localized abscess. So just watch, change the antibiotics, no need for surgery. And so another question which is frequently asked is how do you differentiate a phlegmon from an abscess? So look at the bottom line. The bottom line is that you can't tell for sure in all the cases, but an abscess will usually have a fluid attenuation and a rim enhancement, and a phlegmon will have low density region and poorly defined margins. But many times the clinician just need to stick the needle and see if they can drain pus or not. Just tell them to, not to puncture any vessels on the way, and that will be good enough. We move on to the retropharyngeal region, which can be a type of spread of the tonsillar, peritonsillar abscess can also spread to the retropharyngeal region. we skip the parapharyngeal region, which can also be affected by peritonsillar abscess. So the retropharyngeal region space is actually a potential space, and that's why I'm showing it here with gas in a patient with pneumothorax and large subcutaneous and deep neck emphysema that clearly show the space, and you can identify the midline raphe, which is in it, and the retropharyngeal region is bordered posteriorly by the alar fascia, which might be seen here, and the alar fascia goes all the way to the diaphragm, whereas the space behind the alar fascia goes all the way to the mediastinum, whereas the retropharyngeal space goes just to the level of T2 to T6 level when the alar fascia fuses with the middle layer. And because of that, the space posterior to the alar fascia is called the danger space, and the retropharyngeal space is just anterior to it. And posterior to the danger space, we have the prevertebral space that actually goes all the way down to the sacrum. Another information that is important about the retropharyngeal region is that lymph nodes can be seen in this region up to only in the suprahyoid neck and not in the infrahyoid neck. And infection that we can see here can be either retropharyngeal adenitis or a complication of tonsillitis with the spread of peritonsillar abscess to the retropharyngeal region. And this is the case of retropharyngeal adenitis. You can see the enlarged lymph nodes, and those are the lateral retropharyngeal nodes of Bouvier. You can probably say it better than me. And we can have some reactive fluids in the retropharyngeal space, and this is not infected. This is reactive. Don't puncture. Wait, give antibiotics. It will likely resolve. And those nodes can become suppurative and cause suppurative adenitis. And similarly, we can also have an actual retropharyngeal abscess, either from extension of this adenitis or from the peritonsillar abscess continuing to the retropharyngeal space. And you can also see on the lateral scan the thickening of the prevertebral soft tissue in the that we used to see on the lateral neck images that we used to get on those kids before we were doing the CTs for all of them. Now, retropharyngeal edema is a non-specific sign. It can also be related to processes in the nearby spaces. As I said, the retropharyngeal space is closely related to many other neck spaces, such as the carotid space, the pharyngeal mucosal space, the paraspinal space, and so in this case, we can see retropharyngeal edema, which is the result of acute calcific tendinitis, which we can diagnose by seeing those calcifications in the upper insertion of the longus colli muscle. And it can also happen, as shown here, in the case of discarded osteomyelitis, which is complicated by an epidural abscess, but also has retropharyngeal edema. The last topic, and we get to the Stone Age, is sialadenitis. which is calculus obstruction of the salivary gland with subsequent salivary gland infection and inflammation. Now, the submandibular sublingual glands are much more affected by sialadenitis compared to the parotid. This has to do with the ascending course of the submandibular duct and more mucinous and basic secretions in those glands that promote calculus formation. For nomenclature, the Wharton duct drains both the submandibular and the sublingual gland and open just in the middle, posterior to the mentis. And the Stenson's duct drains the parotid and it opens opposite to the second molar in the upper jaw. And clinically, when a patient has sialadenitis, he presents with salivary colic, which is a pain when he salivates, when he thinks about food, or when he eats. So this is a case of sialadenitis. We can see the swelling of soft tissue and haziness around the submandibular gland. You can see the dilated submandibular duct and the stone obstructing, and you can also appreciate that the sublingual gland is also affected when you compare it to the contralateral side. And this is another case, just to show that you can have signs of the submandibular infection. You don't see the dilated duct for some reason, but once you see the stone, you know this is sialadenitis. And it seems to me, at least from this case, that size doesn't matter for sialadenitis, because here you see the inflammation and this tiny stone that caused the obstruction. And you can also have parotid sialadenitis, and you see the Stenson duct, which is dilated, and the enlarged parotid gland. And note that you need to look in the bone window, because if you try to find the stone using the soft tissue window with all those artifacts, you might miss it. And just a case of parotiditis, which was incidentally scanned in a child that complained about a pain in the right side of the face. So he was thought to have trigeminal neuralgia and underwent MRI. We didn't find anything along the trigeminal nerve, but we found that the parotid gland on the right side has high signal on T2 and diffusion restriction, therefore compatible with parotiditis. We can get some complications from the deep neck infections, either infection and extension to the mediastinum, and vascular complications such as thromboembolism and arterial injury. How are we with time? Do you want me to finish, or do you want to do the quiz? Okay, 2 minutes. Lemierre syndrome is an uncommon and potentially life-threatening complication of acute upper respiratory tract infection. It happens most commonly in healthy adolescent and young adult, and this is a septic thrombophlebitis of the internal jugular vein, in which septic emboli are spread in the body and can also cause pulmonary emboli. And the positive organism is usually Fusobacterium, which is an anaerobe. And you can also have arterial complications. This is a case of scalp-based osteomyelitis, complicated with arterial dissection. You can see the influx in the brain, and you see that. Okay, you need to know where to point. You can see the abnormal signal in the right internal carotid artery, and on the CT angiogram, you can see the dissecting aneurysm in the internal carotid artery from the inflammation of the skull base. So, take home message. Don't forget the airway. Drive your differential based on the next spaces involved. Remember that there are three main categories. Don't panic. Is it dental? Is it tonsillitis? Is it cialipiasis? There are other uncovered issues, but this will cover like 75% of the cases. And remember that not every fluid collection is an abscess, and it can be reactive. And look for the vascular complications because nobody else will look for them. This is your job. And don't forget.
Thank you so much, Ayelet. I know it's a very difficult topic to give lecture for. Thank you so much.